Microscopic exam of urine sediment. All right, remember the whole thing with microscopic exam is that you got to have a standardized amount. You have to centrifuge it properly, and you need to make sure that you view it properly. So remember, all of those things are, make for an accurate measurement for your microscopic analysis. So you should remember, you should use 12 mLs, 10 to 12 mLs centrifuge. You should have 0.5 to 1 ml left, and then use the calibrated slide, which gives you about 100 microliters, I think, goes into each one of those little slides. Now, the Sternheimer-Malvin stain is the stain that is what we associate with urinalysis. Some labs use it. Some labs have no stain whatsoever and never use stain. So this is the stain that is associated with urinalysis, such as Gram stain is associated with bacteria or microbiology, Wright stain with hematology, and you can see some of the cells better. You'll see white cells, the nucleus, and I think we stained a couple, and I'll show you in here. I think I have a couple pictures of it being stained. I have never seen this 0.5 toluidine. Sometimes they'll have just some stain sitting around. I've never seen that. Acetic acid can be helpful for white cells, because what it can do is lyse the red cells, and then it accentuates that nucleus on the white cell. If you need to use a fat or a lipid stain, such as Sudan 3, oil red O, you can then confirm that you may have an oval fat body, for instance, but you really should look under a polarizing microscope, because you'll see those Maltese crosses for fat. You can use a Gram stain. You can use Prussian blue to see if there's any hemosiderin in the urine. And Hansel's stain is a specific stain used for eosinophils for acute interstitial nephritis. And that is a very specific type of procedure to see if you have eosinophils in the urine. Those eosinophils are associated with renal stress due to taking medications. Maybe they're giving a patient some heavy-duty antibiotics, and they want to see the effect on the renal system. So they'll look for eosinophils. All right, now what should you do? First, you want to look at those formed elements. Red cells use high power. They are biconcave. We know that they look smooth. By your experience now, you should be able to tell a red cell from a white cell, no problem. As urine sits, especially in urine that is maybe hypotonic or low specific gravity, those cells start to swell and they'll look larger. Sometimes you'll even look and see that you'll see ghost cells. Now, alkaline urine promotes cell lysis. So in highly dilute alkaline urine, you're going to have more cell lysis. Now, normally you only have about 0 to 3 RBCs. When the dipstick comes positive, you have more than that. And I believe the dipstick is like 8 to 10 RBCs are usually seen per field. Now, RBCs go along with bleeding, either renal bleeding or glomerular or tubular bleeding, because remember, that does not come from the actual filtrate. Red cells do not sneak through that sieve that we call the glomerulus. You can also see excess RBCs, maybe if you have menstrual or hemorrhoidal bleeding, that is contamination. Now, if you have a positive chemical test and you don't see those RBCs microscopically, it can be because they are lysed and you are now detecting hemoglobin. So You can also get a negative test with, look at here, ascorbic acid once again. And you can also have myoglobin present. So if you dip it, you don't see any red cells and it's coming positive, you can, of course, you're going to report out that the blood is positive, but it can be associated with myoglobin. If you have a patient, for instance, that was electrocuted, electrocution gives you myoglobin in the blood, and which is filtered out in the urine, and you'll start to see it in the urine. I had a physician one time that said, I want to send this urine off for myoglobin, and I said, well, the blood is negative, so the myoglobin is negative. He didn't realize that it tested for both. So if you dip it, it is negative for blood. It's also going to be negative for myoglobin. I said what you need to do is maybe wait, because the guy was just electrocuted and they were doing things with him. I said give him a couple hours and then collect the urine again. Give the renal system time to actually filter out the myoglobin. All right, formed elements. Here are your RBCs. You can see they're smooth biconcave discs. They can also look crenated depending on the the osmotic or hypotonic amount in the urine. Notice here you have smooth, there's a smooth one. These are crenated RBCs. Notice how they look like they have little spicules on them. Here, once again, these are all RBCs, okay, RBCs. All right, WBCs, they do mirror what is going on in your peripheral blood. So most commonly you're going to see neutrophils. It is very uncommon to see lymphocytes or eosinophils unless you have some other thing going on, as I discussed earlier. Now, in urine that has bacteria or other things, after that urine sits for a period of time with those neutrophils can become very excited, the granules become enlarged, and we call those glitter cells. Some labs do report out glitter cells, some don't. They don't say they're significant, but they are very giant neutrophils that have these big, huge granules that look like they're almost pulsating in there. Now, we already talked about what the normal values are for leukocytes. Anything under that, you will get a negative on the dipsticks. Any discrepancies with microscopic and chemical, you need to, evaluate. Remember, if you're getting a positive on the dipstick and you get negative when you're looking at the microscopic, you need to figure out why, all right? Because you should have some cells there. I've always gone back, and if I didn't see anything, I would re-dip the urine and even make a notation, double-checked, and it's still positive, but I'm not seeing those cells. WBCs other than neutrophils can be present, but of course you're not going to have a positive. Here are some examples. This is Sternheimer or Malbin stain. Notice how it's kind of little purplish. You can actually see the nucleuses in there. See the nucleus? Here's a good example of this one. Shows you a nucleus of a neutrophil with 2 red cells. So shows you the size and the difference in how they look. Here's another one using a different kind of viewing, no staining. Squamous, your types of epithelial, squamous, transitional, or renal tubule. You want to visualize and enumerate. Many labs enumerate on low power and then go to high power for observation or say what they are. So make sure you follow your lab's protocol on how to report them out. So squamous is the most common contamination. It is almost everywhere. It is that little flagstone type of looking cell. Here it is. Notice it's like they look like little flagstones with nucleuses. Squamous epithelial cells can be a sign of contamination, can be vaginal contamination or urethral contamination. This is why you want to get a midstream urine so that some of those first cells are washed out with that first urine that they put in the toilet. When they catch the middle part, you're hoping not to get as many of these. All right, your transitional epithelial cells are cells that are higher up in the renal system, usually the renal calyces, renal pelvises, ureter. The bladder does have some, so it's actually the lining in the bladder where it's not in the actual ureter. Now, normal urine does contain a few of these because you constantly slough them off. If you have a urinary tract infection, many times you may see more. You may see packets of them, so to speak, sheets of them. Here they are. Note they look different. Notice they're kind of pear-shaped. The nucleus fills the cell more. And here's another one. Notice here. See them? They kind of look a little pointed. And many of them have one flat side. See this one flat side? This looks like a renal tubular. This is a transitional cell. Now, your tubules are lined with different types of epithelial cells. And that's what we call the renal tubular epithelial cells. These are more significant if you see a lot of them. These cells are very round with a very large nucleus. Here's a good example of one. Here's a white cell. This is a tubular epithelial cell or a renal epithelial cell. Now, collecting duct are rarely reported out. We'll just say it's a renal cell because they look a lot like a renal epithelial cell. Some of these you can see, notice how large the nucleus is, and these are the ones that have the flat edge. I said it was a transitional. It's not transitional. It's the collecting duct. Let me see if I have another example. No, and I don't have any good examples in an actual microscopic where it shows the flat side. Now, a oval fat body is a renal epithelial cell that has absorbed fat. Now, it can be an indication of glomerular dysfunction, renal tubular death, or leakage of plasma components into the urine. Usually when you see an oval fat body, it is an indication of a renal problem. So here's an example of a renal tubular epithelial cell or an oval fat body. Notice these little dots inside here. Now you can either put this under a polarized light, so you'll see a Maltese cross. See here? And I don't know if I have a stain. So this is actually this group of cells under polarized light, and you'll see the Maltese cross. Now here's another example. Here's a oval fat body. Here's some red cells around it. Notice under the polarized light you'll see the Maltese cross-like formation. Now casts are unique to the kidney. They are formed in the kidney as the TAMS horsefall protein comes down through the tubules. What happens is that matrix will make the cast. Now, as the cast is flushed out with the urine, it will determine the type of cast it is. So, casts are influenced by an acid pH and an increased concentration. So if your specific gravity is high and you have acidic conditions and you have protein, chances are you're going to see casts, because those are the conditions that you will have more casts forming. Now, clinical significance of cast varies from problem to problem. Hyaline, finely granular casts are very normal. Those are the ones you're going to see when the guys go out and exercise and put stress on the kidney. They are very light, and remember, the first time that you saw a cast, you're like, oh, now I see. It's not that real bright, refractive thing. That this is a very light, sensitive formed element. You want to make sure that you have your microscope in the correct order. You want to make sure that it is low light so you can see them. Now, if you see waxy casts, and how are you going to know if they're waxy casts? Well, you're going to see large amount of protein. This is a very bad diagnosis. So if you see a waxy cast and notice what it looks like, it does look like a piece of wax broken off. But remember, you're going to see like 4+ protein. You might see some other indications of renal failure in there. So make sure that you have all of those indicators before you report out waxy casts, because those are the ones that have a bad prognosis. This says waxy, but this to me almost looks like artifact every time I show this picture, because they're very outlined. Do you see this? I would like to look around and see more before I call this a waxy cast. But remember, there are other indicators. Does this patient have a lot of protein too? All right, now your red blood cell cast is that cast that is basically made up of that hyaline matrix. But the deal is that red blood cells are embedded in the tubule. All right, so it gives you that RBC cast, or that muddy looking cast, because as that cast goes through the tubule, those red cells then kind of degenerate, but they are stuck on that cast and give it that muddy or tinged red look. So you can actually see formed red cells on the top of this cast and some that don't look formed, just muddy looking. That goes along with glomerular nephritis, as the question that we had earlier. Here's an example of a muddy cast, or a red blood cell cast. Note that it does have that muddy appearance. The urine also looks muddy. It looks like that brownish muddy appearance. All right, here's an example. Note here, a lot of free red cells, and then here you have the red blood cell cast. All right, now your white blood cell cast is basically, once again, a hyaline matrix, but where are those white blood cells? Well, they're coming from up high, through in the tubules, which can indicate that you have an infection very high in the tubules, or what we call a kidney infection, that's what a lot of people say. I have a kidney infection. Remember that? When really and truly they have a bladder infection. So this is a upper type of urinary tract infection, meaning that there's some sort of infection in the actual kidney itself when you see white blood cell casts. Here's an example. Notice, looks like there's a clear matrix behind it, and notice the white blood cells on top are embedded into that matrix. Here's one using the Sterner-Malvin stain, and notice how it kind of shows you the nucleus right on top. You can also have some renal tubular cell casts. You can have epithelial cell casts stuck once again in that matrix. But they're showing too that you have tubular injury. Remember, as those cells that are only a unilayer coming off of the tubule, as they're sloughed off, if they're sloughed off in high proportions, you know that you're having some tubular damage going on. All right, so these are not good indicators of things going on. You can see here, you have, they almost look like oval fat bodies stuck on a cast. All right, they are not a good indicator. They're saying that something's going on in your tubules. Now your mixed cast, you can see quite often, you'll see sometimes a granular type or white cell or some red cells stuck on there if you have a combination of a urinary tract infection or urinary tract infection. So you can report out granular, anywhere from fine to coarse. Coarse meaning that you know, it is not as disintegrated, to fine meaning it is more disintegrated. You can also see these in completely normal people. So granular cast can be considered normal or pathological depending on how many you find. So you can see here that, notice they have a lot more granular appearance than that hyaline, which just looks maybe just a little spotty, where a granular looks like it's full of granules. Now, an inclusion cast can be anything that is stuck on the cast. You can see some that even are crystals, such as calcium oxalate, can be stuck on the cast. Most of these are not significant unless you see a whole lot of them, and it can be an indication that the urinary system has slowed down. So if you have, for instance, calcium oxalate stuck on casts, that could mean that you have maybe a renal calculi that has obstructed some part of the kidney, and you have those crystals being formed, and your urine is being formed very slowly. It's not moving through the tubules as fast as it should. Now let's look at some of the lookalikes or junk. Here's a piece of fiber. First time you look at urine, you always want to call this something. This could be toilet paper, clothing, pieces, etc. Now let's look at the crystals. Excuse me. Now, how are crystals really identified? Number one, look at the pH and the solubility. All right. Number one is the pH. Easiest thing. Glance down at your urinalysis, chemical report, look at the pH. If you have pH of acidic pH, for instance, then look at the casts that are more common in acid urine. So if you think, oh yeah, it does look like uric acid, look to see if the pH is acidic. All right. Most of the time in freshly voided urine, you will not see a lot of crystals. But you can, and they can be totally normal. Urine that is refrigerated, you're going to see a lot more. All right, here's a list of your acidic urines. Let's go, and I think I have a few pictures. We'll go through these real quick. Amorphous urates are the ones that really cause problems because they have that brick red or pink red color. When you centrifuge that urine, it almost looks like a pink sediment on the bottom of the tube. All right, that is totally normal. It's from urine that's been refrigerated. And it causes a lot of problem because if you try to look at it microscopically, it just fills your field with junk. Okay, this is what it looks like. Remember, don't confuse this with bacteria. All right. Uric acid has more than 12 different forms. If they are the needle-like forms, they are called monosodium urates. Remember, where do we see the needle-like forms? In knee fluid, toe fluid, gout, okay? But what we normally see in urine is we see the diamond or football-shaped, I like to call them, and they're kind of yellowish in color. That is the very common form in urine. All right. This picture doesn't give it the good idea that you should, but you can also look at these little cross or Star Wars forms, I call them, and then you have the little football forms. Here you have then these plate-like forms. Yeah, and here you see more of the football forms. See these? And then as it sits, they kind of gang up, and you get this little form that looks like it's forming into a ball. Uric acid is totally normal. It is a normal crystal unless you're seeing a lot of it in totally fresh urine, and that fresh urine also has RBCs. Okay, because that can mean renal calculi for any crystal, really. All right. Calcium oxalate, another totally normal crystal. We see calcium oxalate in its basically in its cross form normally. Now you'll see the dumbbell shaped form if the patient has drank ethylene glycol, because you have oxalates, and what you'll see is that unusual dumbbell form in their urine. So if you see that, think about, you know, the patient drinking ethylene glycol. You know, you're alcoholic, and here they are right here. Notice they look like they're unusual, because if you see this, you're like, what the heck is that? Okay? It is not the typical cross shape of calcium oxalate, but this is a form that you will see if somebody ingests ethylene glycol. All right, now bilirubin. Bilirubin is very unusual to see unless that urine sits and the patient has bilirubin in their urine. Remember, on the chemical, you're going to see a positive on the chemical. Don't think you have a bilirubin crystal if chemically it's not there. All right, bilirubin crystals are here. See these little cross things? And they are very unusual to see. I have to tell you, I've never seen them. I expect if we took one of those urines that had high amounts of bilirubin and maybe kept it in our refrigerator for a couple weeks, we might see them form. All right. Now, cysteine. Cysteine is one of the few pathological crystals, okay? It indicates congenital cystinosis or cystinuria. So if you think you have a cysteine there, make sure indeed that's what it is, because you will only see it in cases where a patient does have a problem. And what happens is this cysteine actually deposits in the renal tubule. Usually these patients come in with renal calculi from cysteine. Okay? Now, it can appear in urine up to pH 8, but usually these crystals dissolve in alkaline urine, so you won't see them in highly alkaline urine. Here they are, and they have what? 1, 2, 3, 4, 5, 6. So cysteine can be described, maybe in a test question, as a 6-sided crystal. Okay, so make sure that you understand that you can have a 6-sided crystal that is a pathological crystal. Now, tyrosine and leucine are both pathological crystals, and usually you will see them in urine that is refrigerated or later on refrigerated. Okay, so when you see them, you want to make sure and confirm that that is indeed what you're seeing. Here you have tyrosine needles, leucine, because it says leucine. Whoops, wait a minute. Let me go back. And tyrosine is a finely delicate needle, are colorless and yellow. And I'm wondering, this form is leucine, I think. They're very rare to see, but if you see crystals that you need really help with, call somebody else over to have a look at them. You can see tyrosine and leucine too with people in going into not renal failure, liver failure, because you will start to see more amino acids that are not metabolized in their urine. All right, cholesterol. Cholesterol is always a flat rectangular plate with a notched edge. It always has that little notched corner. Now you can see cholesterol in normal urine, especially if you refrigerate it. It is very unusual in fresh urine, but you will see it in urine that is been refrigerated for a long period of time. You can also see it in patients with nephrotic syndrome because they have a tendency, of course, to have holes punched in that glomerulus and other things leaking through. So they can actually have more fat in the urine that can crystallize. And notice the notched edge, always in the corner, no matter what shape. See these notched edges? That is cholesterol. We found cholesterol once when we were doing urines in student lab, and the student called me over and says, I have cholesterol. And I'm like, get out. I've never even seen it. And sure enough, it was cholesterol because we had refrigerated it. And it had time to form. So it was really cool to be able to see that. All right, now some other things are, which are unusual crystals. You can actually get drugs such as ampicillin. Ampicillin, it looks somewhat like tyrosine, leucine crystals because you'll see them in these sheaves or needle-like projections in the urine. Sulfonamides, some of these actually can be confused. If you looked at that calcium oxalate from ethylene glycol, it kind of looks like it, but you can see there's a lot more of them. All right. Once again, as the urine cools is when you're going to start to see this. So if you're looking at urine in the time frame that you should be, you shouldn't be seeing these things because they won't crystallize out in that amount of time. Now your radiographic dye, you could see here, boy, it just looks like a bunch of sticks in the urine. And if you look at it microscopically, you're going to go, what the heck are those crystals? In this particular case, I would report out unidentifiable crystal, many, and many times that then goes along with the fact that this is the radiographic dye. What you can do is actually do a refractometer. If you see these, go to the refractometer and do specific gravity, because the specific gravity will be really high on the refractometer. Remember, on your dipstick, it'll be normal. And that kind of tells you, this patient probably had an IVP. They should have waited to collect the urine. They're collecting it too soon because that dye has not been flushed out. All right, now for alkaline urine, we see then the amorphous phosphates. That is that white stuff, and it's a huge amount of white sediment in alkaline urine. And when you put it on the microscope, it once again covers the field and you can't see anything. All right. Now, triple phosphate is the one that looks like a coffin. So if you see your urine is alkaline, you're going to see these little coffin lids. That definitely goes along with triple phosphate. Here's some examples. Here's the normal coffin lid of triple phosphate. These are some other forms of triple phosphate. I have seen these. You can see these. They almost look like a butterfly with an X, but it is also triple phosphate. Now, calcium phosphate is one that you can frequently see. Sometimes it's overlooked because it almost looks like artifact. It is totally normal. Once again, it is crystallizing out in normal urine. All right. Now, ammonium biurates or ammonium biurate is called the thorny apple. This is really cool to see. Once again, it can be totally normal in urine, especially urine that is refrigerated. But when you see these, they are very distinct. They do look like a little apple that has little spicules on it. And if you look at the urinalysis book that we use, the graph book that we look at the pictures, on the outside of the book she has a thorny apple crystal, and it looks really distinct when you see it. Calcium carbonate, of course. Now, calcium carbonate, you can see this does look like, once again, that calcium oxalate that is from ethylene glycol, but you can see they're very closely related, and maybe in that particular patient you could also see some calcium carbonate. Totally normal. All right, mucus threads. Mucus is then can be secreted by totally normal people that you maybe have a little inflammatory process going on, maybe your urine is concentrated, and you will then have a lot more mucus. If you have an infection, many patients with infections, when you go to look at the urine sediment, sometimes it almost looks like snot, and that is your response making more mucus, okay, to slough it off inside the ureter area and bladder. All right, now bacteria, this is a little hard to see, but bacteria, remember, most commonly is rods, but you can also see cocci. Very difficult to tell on just a particular slide like this or a wet prep. You would have to do a gram stain in order to determine exactly what it is. It's where you would do a culture. Your yeast, look for the budding yeast, and here's a big squamous epithelial. And note too that when should you really look for yeast? With a positive glucose. Usually patients that have positive glucose, you'll see yeast, because yeast love that high amount of glucose. All right, here are some oval fat bodies. Notice your fat inside the cell. This is a renal cell showing then your fat inside that renal cell. This is the Maltese cross that goes along with the polarizing of fat. Hemosiderin, you have to use Prussian blue to see it. Say if you have a patient that had a hemolytic transfusion reaction or they have hemolytic anemia, you may see that using Prussian blue. Just like in hematology, remember you use Prussian blue to see iron. That's what you're doing here, hemosiderin. Now some of the other miscellaneous things that you can see, spermatozoa. Is it significant to report it out? I always note it. Spermatozoa seen. It could be significant, say if you had a child and you saw spermatozoa. So you might call and say, are you sure this is the correct specimen? Because I'm seeing something that shouldn't be here for a child. And then maybe they're going to go, oh, we got that mixed up. Okay, you better have got it mixed up. Otherwise, we've got a DCF case here of child abuse. All right. But they can be significant, and maybe an older male who has prostatitis or something of that sort going on. Sometimes when people have cardiac failure or they have an MI and they're brought back, remember most things basically open up, so you will see then spermatozoa in the urine at that point in time. So depending on what's going on with the patient. Trichomonas, of course, very difficult to see. You can see here, notice its little flagella, and we see trichomonas as contamination from vaginal area. So many times if a patient comes in, a female patient, with trichomonas, it will cross over into the urine and we will note it in the urinalysis. And then they can treat the patient because they know this is what the patient's problem is. All right, and here we have Cynthia's favorite, the clue cell. Okay, here you have a squamous epithelial cell, notice here, and it is covered with bacteria. This is an indication of an infection with Gardnerella vaginalis, or what they call vaginosis. So if you do a wet prep of the vaginal area and see clue cells, You would note it. You would also note it in a urinalysis because it can be an indicator. It can show that maybe this patient is having a vaginal or a urogenital type of problem instead of a urinary problem. Now, artifact. You can see some urines that have huge amounts of artifacts, and sometimes it is because the nurse was very lazy. The patient actually defecated in the bedpan and urinated in the bedpan, and they pour off the urine. Because in their mind it's like, well, you can still do a urinalysis off that urine in the bedpan. And this is the kind of stuff you'll see. It is okay to report appears to be contaminated with feces. You guys know what feces looks like because you've looked at it doing O&P exams and even gram stains. It is filled with a lot of food material, all right? And you should reject this type of specimen or note it that it appears to be contaminated with feces, request new specimen. Starch. Starch are very large granules with, they have kind of big central pallor. You can have a lot of starch contamination, say if the patient used cornstarch powder, on their private area because they were chafing or they sweat a lot, and then they give you a urine specimen. You hold the cup, some of those granules are going to go into the cup. It's just common, all right? So know that they are not significant. Fibers we already talked about. Talc, you can see that almost looks like starch, not significant. Talc and gels sometimes that patients use. Pollen grains are usually, they usually have somewhat of a color to them, pollen, but they look very significant when you look at them and you think, gosh, that looks like something, but usually it's contamination from outside. Some of the artifacts too that you can see maybe Interrobius vermicularis, the pinworm, can be part of a contamination in a urine. And who is this? Giardia, the little old man. You can get that cross-contaminating into urine. And then here's a little thing. What are these elements in here? What are these? Yeast. What is this? White blood cells. Okay. So you have yeast and a lot of white blood cells. All right, let's go on to renal disease real quick because knowing the picture about how to look at a urinalysis and report it out is probably the most important. Few things about renal disease. And what that glomerulus, remember you got to protect your glomerulus here, because if you have post-streptococcal glomerular nephritis, what happens is that glomerulus then is covered with those little antigen antibody complexes. What happens then? Calls complement over. Complement starts drilling holes. What's going to happen? It's going to drill holes right into this glomerulus. What are you going to get? Leakage of more blood, more protein into the urinary system. What are you going to start to see? You're going to start to see red blood cell casts and blood in the urine when you have glomerular nephritis. All right, so you can also see oval fat bodies, because think about where that disease process is happening, up in the glomerulus. All right, now systemic lupus, you can also get the same kind of thing. Remember, once again, antigen antibody complexes bind, settles on top of the kidney or the glomerulus. What happens? Calls over complement, because that's what initiates complement. Complement starts drilling holes and damaging the area where these complexes settle. All right. Now, you can also have amyloidosis, diabetes. They can also cause problems to the glomerulus, and we will see that in usually one of the first indicators, protein in the urine. Now, nephrotic syndrome I talked about earlier, heavy proteinuria. It is a huge class of diseases. Many of these nephrotic syndromes can go away on their own or move on to more severe renal problems. All right. Now, renal glucosuria, we know from diabetes over long periods of time, this can cause problems in the renal system. Remember, high levels of glucose not only can cause problems to the renal system, it can cause problems to your circulatory system. All right. We talked about cystinuria. I'm not going to go over that again. We did that. Fanconi's is also a syndrome that you will see cystine depositing in the tubules. Urinary tract infection, we've talked about this all the way through. What distinguishes as an upper from a lower. We've already talked about this. Acute renal failure, remember, acute happens suddenly. Many patients then start to have increased BUN and creatinine in their blood, decreased urine output. They start to feel bad. They go to the emergency room. Chronic, of course, is a slow progression over time. All right. Now, you can have other diseases, other things that are unusual. Maple syrup disease, that's very unusual. Gives the urine kind of that maple syrupy odor that goes along with it. Now, here is a case study. And you can see this guy, of course, if you remember this from way back, is a normal male. Notice he's got lots of red cells, few bacteria, 20 to 30, and some unidentifiable crystal. Here's the crystal. What is this? 1, 2, 3, 4, 5, 6. It's a 6-sided crystal, so this is cystine. All right, now you have a 10-year-old. He just had a sore throat, a strep infection. Now take a look at his urine. Look at the protein, very high. Look at the fact that he's got blood. Where's the blood here? Glucose, protein, leukocyte. Here it is, moderate blood. Okay, both of those things right there tell you a good chance of glomerular nephritis. Now, check this out. He's got casts. Look at 2 to 5 RBC casts. What does that tell you? Glomerular nephritis. Here they are. Look at those casts, those muddy casts that he's displaying. Chronic glomerular nephritis. Chronic, I don't know about chronic if there is such a category. Usually what happens is glomerular nephritis comes on acutely and then may go to nephrotic type of syndrome afterwards. I don't know if you would see the amount of red blood cells. I don't know the answer to that question, but it is always associated with glomerular nephritis. Okay, let's take a little break and then we're going to do body fluids.